Good evening, everyone, and thanks to Dr. Charles and Dr. Duseja for this invite. So we all know that alcohol-associated liver disease is one of the leading indications for liver transplant worldwide. In most programs in our country, that accounts for about a quarter to a third of transplants that we do. However, this particular indication is a little different from others, and you heard Dr. Joyce say a little while ago that most of the transplant indications are still based on urgency. Here, however, you have a cohort of patients who are extremely sick, and there is also another angle to this illness, which is their psychosocial suitability. So these are patients who need a very careful assessment for the risk of alcohol relapse in the post-transplant period, and therefore we need behavioral and psychosocial evaluation also as key components of listing these patients. And many a times these patients might be having a cognitive impairment, or they might be encephalopathic, and you might not even be able to triage a patient. So this patient might be brought to the hospital by the next of kin in an encephalopathic state. So the traditional view has been that the duration of abstinence from alcohol prior to liver transplant is the main determinant of post-liver transplant relapse or recidivism. So there has been recent reservation about the use of the word recidivism, because they say that this probably got to do with the justice system rather than the medical parlance. So let's call it relapse for the time being. However, we know that in recent times we've been transplanting very high acuity patients with severe alcoholic hepatitis who quickly transition into high grades of acute and chronic liver failure, and in these patients clearly the conventional 6-month rule may not apply. The patient will be no more, and therefore there will be no transplant happening for this patient. Now, where this 6-month rule came from is still very obscure. Many decades ago, and that was in the mid-80s, it was shown that there was, when transplantation was just becoming the standard of care for end-stage liver disease, it was shown that in patients who had an alcohol-associated liver disease, the social inclusion versus the social isolation, the perception that this patient had a very important disease, their reluctance or their acceptance of treatment for the same, and their psychological comorbidities, these were the 4 main angles that needed to be taken care of before advising transplant. So these particular things still happen have happened over a period of time as we have been transplanting these patients. Now let us first divide, because we all know that ALK-HEP came only after Philippe Mathurin's paper in the New England Journal in 2011. But were we not worried about this as an indication earlier on when we were transplanting these so-called alcohol cirrhotics? The answer is no. So there was some seminal work which came from University of Pittsburgh, and this was Andrea Martini's original paper in liver transplant, wherein you can see that on multivariate analysis, the sobriety period in months, the diagnosis of alcohol dependence. So mind you, relapse is not the same as AUD, which basically encompasses the definition of alcohol dependence, and a stable partner. So these were the 3 factors which were found to be suitable. Now please remember, this is a small subset of patients, 167, but over the 4 years, as you see, whether it is with respect to the first drink or the binge drink or the frequency of alcohol combination, that is pretty much the same at 4 years of follow-up. So that means you might want to say that you are indulging in hazardous drinking vis-a-vis an occasional slip, which most of us in the transplant community don't pay much attention to, but you can easily see that once you start taking alcohol, it's only a matter of time where this particular habit will go out of control. Now what about the period of sobriety prior to transplant? So again, these authors showed that, now let us look at this. This is in the first 18 months post-transplant. So if you are looking at a sensitivity of say 80%, that means these are true positives. You were sober when followed up for 18 months after transplant. But where does this intersect on the x-axis? This is, mind you, 1 minus specificity. So this is a false positive. So that means only 60% of the times this would be specific information. So there is no real period of sobriety after transplant which can tell that this person is going to abstain or this person will not have a relapse. However, it has been well shown that longer this period, the better it is, and lower the chance of this patient having a relapse. So what about the various ways in which you start to have a relapse? So this was again very elegantly defined by these authors from Pittsburgh. So you can see there is a group which has a complete abstinence, there is a group which has a fluctuating level of use which is low. So these are these two bars. And then the third group is the one when there is an early onset and they peak pretty early too. And then there is the group which has a steady increase, which is this deep blue bar. And then there is the group which has an early onset and which continues to abuse alcohol. And we still see this in our cohort of patients, and this is probably one of the finest studies in this space. So does this mean that there is only something to cope up with from the psychosocial aspect? The answer is no, because alcohol relapse after transplant leads to graft injury and it can lead to graft failure also, and many a times it's clubbed with drug defaults. And many of these patients, when you biopsy them, you see not just the stigmata of alcohol injury, but you also see the TCMR changes. And this was shown that in these, the groups which were group 3 and group 5, that means those which started early onset and rapidly accelerated, and those who had an early onset and continuously increasing over the time, these were the two problem groups. And these were, when they were pitched against the other 3 groups, you could see that on all these 3 indices, there was greater graft injury. And what was the experience from the other side of the Atlantic? So this is again one of the largest studies that has been done in this space. This was the European experience, and this was the high risk alcohol relapse score, which is based on the pattern of drinking before transplant, the daily number of drinks, and prior alcoholism treatment for these patients. So this gave a score of 4 or more, which was supposed to have a high HRAR. And then if this, along with the psychological comorbidities, and if the period of abstinence was less than 6, you could see that if all these 3 factors were fulfilled, then you had probably 100%. But you can see the numbers are small. So this is a cohort of patients that is likely to relapse. But why this particular problem has not got the attention that is due to it is that it does not really affect the survival. So those who have not relapsed versus those who have relapsed, when you follow them up over a long period of time, you find that this is not really very significant. And also, as time passes by, there is a kind of a plateauing effect on the percentage of relapse that you see. So the important message is that the period of sobriety is important, and if you had no insight into your problem, you are having high number of drinks prior to transplant and you had any psychological comorbidities, and this could be anything. It could be a personality disorder, it could be a post-traumatic stress disorder, it could be anxiety, it could be depression. So all these things need to be figured out well before we are listing these patients. So the Saroja Bangru from Dallas, she sent off a questionnaire many years after the seminal Philippe Mathurin's work, whether centers in the US were willing to transplant those who had severe ALCAP and were not getting better with medication, and those who were not willing to offer transplant. And we found that on all these questions, there was really no difference between those centers which wanted to transplant and those who did not. And this was a questionnaire which was sent out to more than 100 plus centers, but only a quarter of them replied. So whether it implies of improvement in function, that is what the naysayers say, that liver function will improve once you abstain, take care of nutrition, and they will get better. Decreases recidivism? No. Improvement in patient compliance? No. This is one particular factor which I couldn't wrap my head around. We all know, and even the naysayers would say that it does improve the transplant, but in this particular publication, they thought there was no difference. And most importantly, this is called the best effect from the UK, when George Best got his transplant done as a cadaver donation and then started to abuse again, there was a decline in the number of donations. So they believe that there might be a negative public opinion if these patients continue to go back to their alcohol ways, and that can effectively decrease the number of donations that happen. So quickly now shifting gears to what is called, what was the standard, which was 6 months sobriety, and for some centers 3 months sobriety, and this was the first publication on early liver transplant. So what is the definition of early liver transplant for the fellows in the audience? Any transplant which is done less than 6 months of sobriety is called an early liver transplant. In most studies, this has been matter of days, so a few weeks, maybe 40 to 50 odd days. And in this particular study, even though the number of patients was small, so what was the other fear? Are you going to take a big cake of the transplant organs that were available? Because mind you, these are all deceased donors' organs and not similar to the situation in our country. The answer was that very few transplants. So just about 10% of all alcohol-associated liver disease and 3% of all SAH would actually get transplanted. And on a 2-year follow-up of this study, 3 of the 20 survivors, because 6 succumbed to infections along the way, they had an alcohol relapse. This was the publication from Mount Sinai. Again, very few number of patients who got transplanted. These were all very, very sick patients, acute kidney injury needing renal replacement therapy. And however, they were also very careful not to transplant those who had respiratory failure. And all these patients, as a part of the inclusion or being listed, had good psychosocial profile. And only 1 out of 9 relapse was seen over a period of 6 months to about 4.5 years of follow-up. So this was the John Hopkins initial experience. Again, you can see that these patients who had length of abstinence prior to transplant 40 days in the SAH group, the time listed before transplant only 6. So they are going to have a chunk of the organs that are available which are being donated, whereas alcoholic cirrhotics had a huge period of the duration of abstinence, and the number of days on the waiting list was also much higher. And you can see very high MELD scores at the time of listing and getting a match. So what these authors showed was that the Hopkins psychosocial score scale allocation, and this is something that we should all, I will just walk you through this slide. So there is a positive score, which means things are good on part of patient selection, which is self-admission, drinks prior to abstinence, insight into diagnosis, stable partner, and abstinence. So this accounts for about +10 score. And then there are 7 particular questions which are all negative. So this score varies from -14 to +10. And higher the score, you know, the better the chance that this patient would not relapse. There are few other scores like the CPAT, which is not specific to liver transplant but across all solid organ transplants, and then the Michigan score and the SALT score. The SALT score was recently used in the Accelerate AH trial, and this was 10 drinks prior to initial hospitalization gave you a score of 4, multiple attempts at rehab 4, prior alcohol related legal issues 2, and prior illicit substance use 1. Score of greater than equal to 5 meant that you were more likely to have a relapse after the transplant. Please remember that early deaths were less than 3 months and late deaths were greater than 1 year. And in this particular study, they showed that late deaths were related to alcohol relapse. The various ways of checking this has already been alluded to in the morning. So you could either have an alcohol timeline follow back questionnaire, which most of us do. You should also interview these patients with their caregivers and the next of kin. Do not allow them to come to your clinic by themselves. And then you could use things like ETG, ETS, PET, so on and so forth, whatever is locally available. But please see again that if you have a probability of survival between those who have had a slip or those, and mostly this is slip, not those who had take alcohol in the sustained alcohol use form, they have no difference in survival from those who do not take alcohol at all. And that is why this particular problem has not got the kind of attention it should have. Recent other studies, in the interest of time, I will not talk about the details. So John Hopkins published its retrospective data from 2012 to 2020. Mind you, all of these studies have shown that any slip is about 25 to 40%, but sustained alcohol consumption is only 10 to 15%, and it is the sustained alcohol consumption which is hazardous with respect to the graft outcomes. When you compare the various projection models, it has been shown that none of them, as you can see, has an ORAC which crosses 0.8. And all of these models have got a high negative predictive value, but they do not have a very great positive predictive value. So to summarize, ladies and gentlemen, the alcohol relapse after liver transplant is a clear and present danger. The psychopathology in a liver transplant recipient, and some studies have shown a younger age and lower period of sobriety, they are the consistent risk factors for relapse. The initial experience with early liver transplant has not given a signal of high relapse thus far. But however, the neurobiology of addiction behavior in general and alcohol use disorder in particular, it needs better understanding to design proper interventions. So we as hepatologists have not been taught enough addiction medicine, and the addiction medicine specialists are extremely scared of people who are jaundiced or who have impaired liver function, and they refrain from prescribing the kind of pharmacotherapy that these patients might need. Thank you very much for your attention.